So thank you very much for the invitation to come and talk to you about the Rancho Bernardo study. You let me know that this was an informal presentation. So what I wanted to do today was talk, give you a little bit of a talk that I gave previously, which was to the Rancho Bernardo Historical Society in March, where they invited us because obviously that's the community our participants came from, and they were very interested in getting an update on the status of the study. So the first part of my talk is really a pretty general overview of the study that was really meant for the community there. So it's pretty high level. And then I will go into a little bit more detail of the description of the study and the data that's available, and with a focus on the cognitive aging for this group. And I just wanted to start out by mentioning that this study was founded and directed by Elizabeth Barrett-Connor. And it was really very special for us to go to the Rancho Bernardo Society in March 2019, because at that time, Elizabeth was in hospice care, but some of her family members, her husband and a couple of her children, were able to come out to that presentation. So it was a really nice time to pay tribute to her, as well as to acknowledge the participants, you know, all of their great dedication over the years. It was a really nice event. So to start with, what is the Rancho Bernardo study of healthy aging? It was is a longitudinal cohort study that was initiated in 1972. It was part of a nationwide lipid research clinic's prevalence study. And in the original study visit that ran between 1972 and 1974, over 6,300 residents of the community volunteered, and that represented 82% of the adults aged 30 to 79. The actual age range was broader than that, but that was kind of the target population that they really wanted to see if they could get everybody. And so that was a really good turnout for a community sample. And then over time, the study periodically opened enrollment again, but only to residents of Rancho Bernardo. So it ultimately enrolled 6,726 participants. And we're still following the survivors today. There's about 1,000 of them. We're following them right now just with annual mailers, or whenever we can afford to do a mailer, to find out about their current health status and other information. So as I mentioned, it began as a lipid research clinic study. That was back in the 1970s when they were investigating the relationship of cholesterol with cardiovascular disease. And so the National Heart, Lung, and Blood Institute was funding a nationwide study that involved several sites to look at causes and consequences of hyperlipoproteinemias. I just love that word, having to do with cholesterol as a risk factor for cardiovascular disease. And was a multi-site study across the country in order to get a diverse sample. And these are the different sites that were involved in the study. So you can see that it represents quite a broad range of different communities across America, and even a couple up in Canada. And all of these studies were, all of these sites collected the same data back in the 1972 on the cardiovascular or cholesterol as a risk factor. But none of these studies turned into a longitudinal study, although I think maybe one of them did do some follow-up. But the Rancho Bernardo study was the only one that morphed into a longitudinal study. And so for the Southern California site, Elizabeth Barrett-Connor was just newly arrived in UCSD at that time, and she was tapped to lead the local study. And according to her, she chose the Rancho Bernardo study because it was the right size. It had about 10,000 people in total, so it was a good sample size. She said it was the right distance from UCSD. So by that, she meant it wasn't too far away for her and her staff to go and do the study. And it wasn't too close so that her participants wouldn't get poached by other studies going on. So she was, very strategic. And then the residents were of the right age. And she laughed. So when I met Elizabeth, she was late 70s, I think. But she had actually written that it was a good community because it had lots of old people over the age of 50. So it was, we don't consider 50 old anymore. And then the study, the sample, the community is very homogeneous with regard to education, socioeconomic status. And that was important for her because it ensured access, that all the participants would have access to healthcare and be able to provide a reliable medical history. Obviously, this really limits the generalizability of this study. It's also very homogeneous with regard to race, ethnicity. They're almost all white participants, non-Latino white participants. This does, so what we give up for generalizability, we get some advantage though for reduction of confounds due to some of these factors like differences in healthcare access and differences in these other factors that can affect a lot of outcomes, health outcomes in aging. And importantly, the community and the developers were very supportive of being involved in the study. And the community allowed them to put, they gave them free space to put their trailer, which was in the dirt parking lot outside of the Safeway. So it was a central location where pretty much everybody in the community went, so that they were very visible to the community. And they were very good at messaging. So their trailer was decorated with a lot of eye-catching signs, the coronary prevention program and stop heart attacks. And so it was a very, and also a lot of the community members were actually volunteers helping to collect the data. So it was a really nice effort by the community. And this is a picture from the Bernardo News in 1972. So why did the Rancho Bernardo study continue when the others didn't? So Elizabeth added on to the standard study protocol. She added a couple of extra pages on questions about other heart disease risk factors. And she obtained separate funding to analyze the fasting blood glucose levels. So they were obtaining fasting blood samples from the participants. And she knew that she was very interested in diabetes as a risk factor for cardiovascular disease, which was very understudied at the time. The NHLBI, though, wasn't interested in allowing her to do that because a different institute studies diabetes, the NIDDK, and they didn't want to, get into each other's territory. So she had to find separate funding, and she did through the Diabetes Association. And this gave her some extra data on which to then launch a study of diabetes as a cardiovascular disease risk factor, and allowed her to get funding to further follow the study. So I've got these couple of quotes from one of the papers that was written about the Rancho Bernardo study in the early years by Mike Crickey, who was writing about non-respondent bias and why it's really important to be able to try to sample everybody in a community and try to continue following up with them so that you're not biased in your results by selective enrollment and by selective loss to follow-up. So he wrote in this paper that community involvement was one of the outstanding characteristics of the present study population. And I think this is very true even into our last visit and even going there right now. And we still have really good responses to our mailers. So they've always been a very involved community. And also the researchers were themselves very, very adamant to get all the data that they needed. And I liked this sentence in the paper, which says, because of repeated phone calls by one of us, this is Elizabeth Barrett Connor, only 3 non-respondents contacted completely refused interviews. So they went and were getting information from people who didn't enroll in the study because they wanted to know who they were and why that was. And she was very persistent. So this reminds me of a story that Elizabeth frequently told when she first came to UCSD, and she wasn't feeling very well respected as an epidemiologist because the department chair said all epidemiologists do is count people, but she responded that, well, at least she was going to count them very well, and she really did. She made every effort to do that. And so one of the other anecdotes about this was for following up with people who moved out of the community, they really did do everything possible to keep track of them. And in one case, another anecdote that I read about there was that one family had moved away. They didn't know, they knew what city they had moved to, but they didn't know any other way to contact them. So what they did was they found out the information of what church they went to because she collected a lot of information from them. She contacted a similar church in that new city and hunted them down that way. It's not something we could do today with our privacy laws, but back then they could do it. And she really kept track of her people. So over time, as I mentioned, there was a total of over 6,700 people that volunteered for the study. And this is a breakdown of the age range of the study participants at baseline. 11% were less than 20 years old. So the Lipid study itself had a targeted enrollment of 12-year-olds and higher with no upper age range. But in order to have, generate goodwill with the community, if a family came in bringing their children and wanted their children tested for cholesterol, she enrolled them in the study as well, and she continued to follow them. So in our database, the youngest I've seen was, I think, a 5-year-old who would have been included in the study at that time, which is why, even though the study started in 1972, we still have a population that we can follow up with because they were young at the time the study started. However, 65% were over the age of 50, were 50 or older, because it was marketed as a retirement community. The participants had moved from across the US, so there was geographical representativeness within the community, even though they were all now located in California. Most of them were married and of Northern European ancestry and middle to upper middle class. So again, this goes to our problem of generalizability. But again, they had health insurance, and most people had a high school education, I think 90%, yeah. And a lot of them were college graduates as well. So they've kept really good track of the cohort. There's very little loss to follow up because of all the efforts that they've made. We have 91% follow up for vital status of the cohort. And the overall mortality is 71%, which reflects the age of the cohort mainly at the time that they were enrolled. And as we were talking at the beginning here, we have been obtaining death certificates from as many of the participants as we can. And so we have that on 91% of the decedents. So we have cause of death coded with ICD-9 codes, and the verification of date of death on pretty much everybody who's died, so that we can redo studies of risk factors for mortality. It's a very long-lived cohort. Their average age at death is about 3 years longer than US averages for both women and men. So 86.4 years for women, 83.5 for men. And we have about almost a third of the sample has lived to age 90 or older, as well as some centenarians as well. And as I mentioned before, we're continuing to follow up with what we think are about 1,000 survivors, where we mail them surveys to find out about their current health status and behaviors. And we have a survey going out right about now, I think. So this is a little cartoon of the study design to show you that it started in 1972. And the initial study was trying to enroll everybody in the community that they could. They're really focused on the adults. They were trying to get all the adults in the community. Then the second visit was just on a subset who had high cholesterol. So they brought them back in, a subset with high cholesterol and some matched samples without high cholesterol to do a more focused investigation of cholesterol as a risk factor. And then after that, Mike Cricky did a study where he was looking at peripheral arterial disease, again in a focused sample of the participants. And then they also started at around that time to begin to mail these participant surveys to find out all sorts of information about them. I'll go into detail about the different kinds of questions they were asked. So we have to date 32 surveys that have been mailed almost annually starting at around that time. And we have pretty good response rates for those mailed surveys. In 1984, Elizabeth got the funding to do to bring them back for her first research clinic visit, which was focused on diabetes and osteoporosis. I think, no, osteoporosis came in visit 5, but this was focused on diabetes. She was aiming to bring back all of the survivors aged 50 and older. And so this was really the launch of what, although even at the time, I don't think they thought of it as a longitudinal study. This was just taking advantage of her cohort to study diabetes. And then they kept going. And I think in terms of having a good longitudinal study where you've really harmonized methods over time, that didn't really happen until a little later in time. But this shows you that we've had a number of visits since then. Up until the recent visit, I became the PI on the study for this visit 12. Elizabeth came to visit me in 2009 in my office and invited me to work with them to try to get funding for brain imaging. So I became involved really at the very end of part of this long history of the study. And it's taken me a really long time to learn everything that the study has to offer. I still don't know it all, but I know some. As I said, we measured, these people were poked and prodded and had every single thing about them measured that she could think of at various points in time. And so in all visits, we measured height and weight. They brought in their prescription medication so we could validate their medication use, as well as supplements and vitamins. Blood pressure was measured at every visit. Sometimes they got x-rays. Many visits had DEXA scans so that they could look at bone density and body composition. They were always queried about their diet, alcohol use, smoking, physical activity. They had measures of cardiovascular health and fitness, lots of cognitive testing, as I'll talk about, mailed surveys. And then at the very end, at the very last visit, so far, we've got some brain imaging on a subset of the participants. So this is a little bit more detail of what our study has collected over time. So we do have APOE status, which was measured on participants at visit 5. So we've collected serum and blood samples from at almost all visits, and we still have many samples available for use if somebody wants to do looking at any kind of biomarkers. We have urine samples from all visits. We recently did an interesting study that was published in JAMA that showed that at visit 5, we could detect glyphosate, which is the chemical in Roundup, in only 12% of the participants, but by visit 12, we could detect that in the urine of 70% of the participants. So it's showing the accumulation of this weed killer in our bodies over time. So that got a lot of attention. So we've got useful biological samples that people, if you're interested in using, let us know, and we'd be happy to collaborate on studies of using those samples. So we have information on cardiovascular disease, diabetes, health status and behaviors, physical characteristics, and psychosocial measures were obtained all across the study, as well as in the mailers for the self-reported variables. We have biomarkers from various visits, like inflammatory biomarkers, sex hormones, adipocytokines, and other hormones from various visits. We verified the medication use, so we knew what they were taking at every visit. And then the cognitive function and physical function tests were introduced at visit 5. And so this is a table that we include in some of our grants just to show an example of the richness of the data set, of the information that's available at multiple visits, including surveys such as quality of life and health status. We find out their number of hospitalizations and doctor's visits, as well as all the measures that we've obtained in blood pressure and cholesterol, fasting glucose. We also have post-challenge glucose, which is more sensitive for detecting diabetes in the population, as well as a number of other biological measures. We have blood measures of vitamin D. I'll talk about that a little bit, and some of the hormones that I was mentioning as well as a number of psychosocial variables. So we have things like optimism and self-perceived happiness and stress, things like that, social engagement. So we have a lot of information about these people. One of the Elizabeth's main interests was in sex differences for a variety of behaviors and health outcomes, but particularly for cardiovascular disease risk. So when she started the study, she was aware that both sex and diabetes were very understudied cardiovascular disease risk. So that was one of the main things she wanted to focus on. And the homogeneity of the cohort is an advantage here because you don't have a lot of differences between the men and women that could confound some of the associations that we're observing. So it is a good cohort for studying sex differences. And they found a number of sex differences in cardiovascular disease. We know that women have a lower risk of heart disease, but she found that cardioprotective benefit was lost in women with diabetes, and that diabetes is a stronger risk factor for ischemic heart disease in women than in men. They also looked at the relationship with testosterone and diabetes, as well as mortality, and they found an opposite relationship between men and women there. In men, low testosterone was associated with diabetes and a shorter lifespan, whereas the opposite was true for women. High testosterone was associated with diabetes and a shorter lifespan. So as I mentioned, they collected a lot of information on alcohol use and diet over time, and what they found was that drinking in moderation, exercise, not smoking, and losing weight were all associated with higher HDL, with drinking being the most strongest predictor of HDL, which is the good cholesterol. They found that people who eat multiple small meals per day have a better lipid profile than people who eat fewer meals but larger, even though the number of calories were the same. And she also reported back in 1988 that a high sodium, low potassium diet increases blood pressure. And this was particularly, low potassium was a particularly stronger predictor, more so than the sodium. So really emphasizing the importance of fruits and vegetables in your diet. Also looked at various behavioral and psychosocial factors. So women who, non-smoking women who lived with their husbands who smoked were at twice the risk of having a heart attack than if their husbands didn't smoke. We also found that women had larger social networks than men, and the social networks were predictive of greater longevity. And more recently, we found that in both men and women, optimism is associated with a reduced risk of mortality from coronary heart disease. So I think a finding that might be of interest to you guys in particular was that the Rancho Bernardo study linked up with the ADRC in 1990. Basically, they collaborated with the ADRC to help choose the cognitive tests that they introduced into their battery. And then they also had a visit with just a subset of the participants in 1990 and 1993. These were people who came to visit 5 and had their cognitive function tested. And then they brought back people who had performed poorly on their cognitive tests, as well as a matched sample of people who performed well, and did a workup for potential dementia diagnoses. And they found that people who had received a diagnosis of dementia based on their neurological and neuropsychological exam, they showed a pattern of weight loss in the 20 years prior to that visit, whereas people who were cognitively normal showed basically a trend towards increasing weight over time. So this was a pretty early finding that's since been replicated, that weight loss does precede dementia. And so this was published in 1996. So this is a screenshot of our website. I'll be talking about that a little bit more, but on our website, we describe the study in very great detail. And I'm bringing this up here to talk about the advantages of studying cognitive predictors of cognitive health in this cohort is that we have 28 years of cognitive follow-up starting from the visit 5 in 1988. And we also have 15 years of prior health history so that you can look at how prior health predicts cognitive outcomes and rates of cognitive change with age, as well as how current health measures do. So we have all of these measures that are obtained at the same time so that we could look at how things change together. So the cognitive tests are limited. So for the neuropsychologists amongst you, you might be a little perturbed to see how sparse the test is, but this was added to a study where they were getting many other measures at the same time, like the DEXA scans and all of the blood pressures and clinical measures. So they needed to have a battery they could do pretty quickly. So what we lose in details of our neuropsychological assessment, we at least make up for in repeated assessment over time. So they had the mini mental state exam, and they switched that to modified mini mental state in 1997 so that we can derive the MMSE score from the 3MS so that we can have a measure of the MMSE over time. They also did the category fluency test of the animals in every visit, trails making test part B, and then the Buschke selective reminding test in most of the visits. And every now and then additional tests were added. I added a few additional tests in visit 12 as well. So as I mentioned, it is a great resource for studying predictors of cognitive health and aging because we have the long cognitive follow-up as well as prior information available. And since I became involved in the study, we started looking a lot at the trajectories of change in cognitive function with age or over time. And we've looked at a number of different predictors of things that we thought may have affected cognitive function. And so Emily Reese, who's one of our ADRC rec scholars, took the lead on this project where she looked at changing cognitive function with age in our participants as a function of gender and whether or not they had obtained some college education. And what we find is not surprising, the participants who didn't go to college declined more steeply over time than those who had higher levels of education. And that there were some sex differences. Women seem to decline a little more steeply on the trail speed test than the men. And in verbal recall, women have better memory performance than men. This is known from many studies. And you can see that that difference persists over time between both men and women, between men and women, regardless of their educational status. And yeah, so then with men, we see particularly a sharper drop off in MMSE performance with age in those who didn't have any college education. Of course, there's a lot of differences between why men and women may or may not have been able to obtain college education. So it's can reflect something different between these associations between education and cognitive function could be different between men and women for a variety of reasons. So Emily also looked at how APOE4 status or APOE status affected cognitive function over time with age in this case. Again, she published this paper in neuropsychology. We looked at both having an E2 allele versus E3 homozygotes or having an E4 allele. And what we found was, as you would expect, the E2s had less cognitive change over time, had better cognitive performance over time, and the E4s had the worst cognitive performance over time. So as you would expect. But we also found that the E4 status modified the association of education with cognitive decline, particularly among the people who didn't have higher education, who were E4 positive, had steeper cognitive decline over time than people with college education who had an E4 allele. So college seemed to mitigate some of the risk associated with the E4 allele. And that was significant for trail speed, but you could see a similar pattern for the other tests as well. And this didn't differ by sex. We also found that the E4 status modified the association of alcohol use with age-related memory decline. And so particularly, we found that on the Buschke total recall test, so the memory test, people who were E4 positive declined more quickly over time, with age, if they were non-drinkers. So it seemed that in this case, they're moderate drinkers, that our cohort is characterized by a high prevalence of regular drinking, but moderately. So, and we don't have very many heavy drinkers. So when we do a comparison of drinker versus non-drinker status, it's typically we would characterize those drinkers as low to moderate drinkers. And those drinkers, so for the E4 status, so drinking alcohol in moderate amounts seem to be protective against the deleterious effects of the E4 allele. In a separate study, we weren't looking at rates of change over time, but we were just looking at the odds of being cognitively healthy at the age of 85 based on your prior history of alcohol use. So alcohol use at, I think we did that in the 1988 visit. And what we found here was that drinkers relative to non-drinkers had higher likelihood of living to age 85, as well as had higher likelihood of being cognitively healthy at the age of 85 versus being cognitively impaired as determined by MMSE performance. So something that we've just, this was done by Ali Alatar, a medical student who came to us to ask if we had information on hearing in the Rancho Bernardo. And so he took the lead on doing a study with us where we looked at a rate of cognitive decline over time as a function of hearing impairment. And what we did find is that there seems to be a dose-response relationship with people with mild hearing loss showing steeper decline over time than people who have normal hearing, and people who have more severe hearing loss showing even steeper decline over time. And I'm going to be talking about the relation between hearing and cognitive health in the gerontology research collaboration meeting on Thursday. So if you're interested in more details there, you could come to that talk Thursday at 4. So these, what we found here was that these results were unchanged with adjustment for cardiovascular measures, social engagement, or depression, factors that could potentially mediate the association between hearing impairment and cognitive function. And it also didn't differ by APOE4 status. So an important thing to think about when we're looking at change in cognitive function over time and predictors of change in cognitive function over time is the fact that things that might be associated with worse cognitive function over time are also likely associated with higher rates of dropout of the study or higher mortality. And so we definitely found this in this case, that the participants who had the most severe hearing loss were far less likely to come back to repeated visits. So their duration of follow-up, the 90th percentile of the follow-up for that group was at 10 years, which is why we restricted this to 10 years, whereas the follow-up in the other groups was longer, could go out to 24 years. And that's because the people with moderate hearing loss were more likely to die than the people with milder hearing loss or with normal hearing. So that's something that you want to account for in your models. And because we have really good information on mortality, we can do that. So in this case, we could do a joint model where we're both simultaneously modeling survival as well as modeling the change in cognitive function over time. And we found that that didn't actually affect our associations here, but it is something that our data set lends itself to having a good way to statistically control for these potential biases. My colleague Gail Laughlin looked at whether vitamin D was associated with cognitive function. So this is vitamin D insufficiency as judged from our blood samples. And even in sunny Southern California, where our participants go outside and exercise all the time, they have a really high rate of physical activity. We even found in this sample that 14% had at least some moderate vitamin D insufficiency. And those participants did show poor cognitive performance that persisted over time. So the rates of change didn't differ, but they were persistently showing lower cognitive performance than people who had adequate amounts of vitamin D. And this relationship persisted with control for all sorts of variables, including other things like the season of blood draw, physical activity, alcohol, tobacco use, and a number of health-related variables as well. And we also saw this association when we limited the sample to people who were in good health or subjectively rated themselves as good to excellent health to try to rule out any reverse causality associations. And then as I mentioned, I became involved in the study primarily to help get brain MRI data available on as many of the participants as we could. We started our attempts to get funding for that in 2009, which the economy was not doing very well in 2009, and it was very hard to get NIH funding at that time. So it took us a lot longer than we had hoped it would. So we didn't actually get funded to start doing this until 2014. And as you know, our sample is pretty old already by this time. So that really cut down the availability of our sample. So we only ended up bringing in 221 participants for that visit. And not all of them were eligible for the MRI study for various reasons. As you can imagine, there's a number of implants and things in these participants with their age range. Not all of them wanted to see what their brain looked like, but a number of them did. And so we got structural MRI, so both so we can look at thickness and volume differences. We had standard diffusion weighted images, and then we had our RSI measures, the restricted spectrum imaging, which is a more advanced method of diffusion imaging, which allows us to classify diffusion on different time scales so that we can look at diffusion, which is the motion of water molecules on a really tiny time scale that would be consistent with diffusion within neurites, so axons and dendrites, small cell bodies. We can also look at diffusion within a slightly larger time scale so that you could get from the extracellular space. and diffusion within free water, which would like in ventricles, and that would be a reflection of atrophy. So this is a way of looking at more microstructural changes within the brain. And Emily Reese, who I've mentioned several times before, she's been working a lot with me in this study. She's actually been the one directing the RSI studies. Maybe someday you can hear her talk in more detail about that. But this is one of the first studies. This is the first study that we've published on the MRI data that we obtained at visit 12. And what she found here was that the correlations of microstructure with age were much stronger among women than men. And we have quite an age range here from 56 to 99 years. And we obviously have more women than men at this age range. But even when she restricted it to an age match sample of the same number of women matched to men, these differences persisted, these very striking differences in that women are showing greater age-related change in all of these three measures of restricted diffusion relative to men. And we have a paper that's currently under review where she's reporting that the correlations of these microstructural differences with cognitive performance are stronger among women than men, which you might expect given that there seems to be a lot more variability in these microstructural measures in women than men. And we're also looking, she also has a paper under review that's looked at the association of these microstructural changes with pulse pressure. And we're seeing differences in white matter microstructure as well as in some gray matter regions with pulse pressure. So you can always talk to Emily for more details on that work. And as a little prelude again to my talk on Thursday, I've also started looking at the differences in brain microstructure between people with hearing impairment and people with normal hearing, and I'm seeing some interesting signal there as well. So we've just really begun to look at the brain measures, so there's still a lot more to be done there. We have all of this information on their prior health that we can look to predict their brain health in later life here. So the data from the Rancho Bernardo study, almost all the data are freely available to you on our website. You could just go there. We wrote a lot of description about the study to really facilitate the ease of use by participants, since I'll show you in a minute, our Rancho Bernardo group of investigators is very small. Funding isn't going to last much longer to support us all on this study. So we really wanted this to be a standalone resource for people to be able to use the data that's been collected over these past 47, 48 years. So if you go to the website and go to these different tabs, you can find a really detailed description of the study, some of the history that I mentioned, all of the different data groups. So we've harmonized the data across waves, and we have grouped them into different data groups. So if you want to look at cognitive function, we have a tab for cognitive function that describes the tests, tells you exactly when they were measured at which visit, and you can download a data set of the longitudinal cognitive data over time. You can then download a data set on all the demographic information or the cardiovascular information, and link that up, and then you can do studies of all of these different predictors of cognitive health. We also have information from the annual mailers, and that information we just because there were so many mailers, we just downloaded basically spreadsheets per mailer. But our website here, if you go to this tab, has a description of what kinds of measures were obtained at each year, so that you can, if you're interested in a particular survey or psychosocial instrument, you can find out when it was administered and look at the data there. We also have provided a list of all the publications that we know of on the Rancho Bernardo study. We don't know all of them, or maybe we've just limited this to our UCSD investigators, because the Rancho Bernardo study data has been shared with a number of consortiums around the world, so we might not have been able to track all of the publications on it. But there's over 600 publications, probably more than that, on various aspects of the Rancho Bernardo study. But so you can always, do a keyword check on the titles to see what's already been done, or if you want to look to see more details about some methods, if we haven't adequately described them on their website, that would be a good resource to look for that. And then the data access tab, you can go there and you just have to agree to, your standard data use agreements of not trying to decode the coding to figure out who the participants are, things like that, maintaining privacy and anonymity of the data. And then if you have any questions, if you're trying to use the data we have, you can contact us or you can email us through there and we can help you. And if you are interested, actually, I mean, this data, anybody can use it. You can do anything you want with it. But if you want to collaborate with one of us, because of our more detailed knowledge of what's going on, we're very open to collaboration as well. Right now, I should mention the MRI data are not available on the website yet. But again, we're more than happy to collaborate. So just reach out if you want to. Same thing with the biological samples. If you have any interest in perhaps measuring something from plasma or serum or the urine, again, we'd be happy to collaborate on that. And the Rancho Bernardo study has been funded by a number of different institutes. My own study was, I couldn't get it funded through NIA. The funding cutoffs were just like too severe, even though the first grant that I ever submitted, the first R01, which was on Rancho Bernardo, was the best scoring grant I ever submitted, and it didn't get funded. But I've been funded since then for grants that didn't score as well. But we were funded by the NIAAA actually to do our Visit 12, where we were getting brain imaging data. So that's part of my focus on alcohol use, is looking at alcohol use and cognitive function and brain measures, because NIAAA was interested in funding us for that. And there various associations have funded the Rancho Bernardo investigators over time, as well as a number of companies as well. And this is our Rancho Bernardo archiving team. We did get a grant to do all that work of harmonizing the data and digging through it, which is very interesting. And I learned a lot about how to design a longitudinal study from going through that. So Gail Laughlin, who's been involved with the study for 21 years, and Donna Kritz-Silverstein for 33 years, these people really know the data inside and out, and our database managers and statisticians. So all of those longitudinal graphs I was showing you, Nikki Bergstrom really did the statistical analysis for us on those. And then Ricky Betancourt also has done a lot of statistical analyses of different studies of Rancho Bernardo, but they were the ones that also did all the data harmonization, built our website, put all the data up there. So it's been really amazing to work with these two people who could do so much work getting our study together there. So I'm going to stop sharing now. And if anybody has any questions or anything that you'd like to talk about, I'd be more than happy to answer questions.
I had a question, Linda. Thanks. I feel like I heard little snippets of that, but it was really cool to hear it all. It's such an awesome study. With the data availability and is the MRI included in that? Is that all of the data that's included?
So what's on our website? We don't have the MRI data on our website yet because we've only just started using it, and we need to make sure it's all curated and clean and everything. But more than happy to collaborate with you on that and give you access to it.
Okay. And another question with the alcohol, how much detail is there on the type of alcohol consumed? So
in general, they were asked how often they consumed alcohol and how many drinks of different types. So they were asked about whether they drank wine or beer or spirits. Most of these participants drank wine. So they were asked, unfortunately, I'm working on the VETA study right now, so the VETA questions are embedded in my head about this, but we do have information on frequency of use, so whether it was daily or weekly or monthly, and also how many per day, so both frequency and quantity.
Very cool, thank you.
Hi, Linda, it's Emily.
Hi, Emily.
Hi, great talk. First of all, it was really, really great to hear the whole story from start to finish. But I was wondering, actually, for those of us who are interested in hearing your talk on Thursday, would you be able to share the Zoom info for that, either through the chat or maybe send it to Christina to share or something?
Sure, I can send it to Christina to share.
Okay, great, thank you.
Did I just make you guys go away? No, I'm still here.
Linda, this is Gary. Hi.
Hi.
Hi. For each visit, when there was cognitive data, did they get a diagnosis, a neurological diagnosis of normal or otherwise?
No, they only got, that only happened on that small subset of participants who came to visit 6, which isn't data that we're sharing because of privacy kind of issues and sensitivity of that data. But no, it's just neuropsych performance. So just using standard, when we could talk about somebody being cognitively impaired, we just do it based on age, education, sex cutoffs for the MMSE, for example.
So there may be something about whether they're cognitively impaired. It's just not a diagnosis.
Right.
Yeah. Okay, great.
And we have self-report, but you know that that's not very reliable.
Thank you.
Hi, Linda. This is Paula Esplat. Thank you for such a wonderful talk, and the study's fantastic. I'm particularly interested in biomarkers, and following with Gary's question. So if you get access to biosamples, will you be able, even if they are de-identified, to confirm like a probable Alzheimer's, or even if patients, do you have Parkinson's patients in your community? I guess you have.
We asked participants whether they had Parkinson's disease, and I know from poring over the medication file that I have seen some Parkinson's medications, but not very many, not enough to do a study on.
Okay, but for the Alzheimer's, then you have this cognitive decline, but not an official like classification of probable diagnosis. Okay. So can you comment a little bit on the process of getting biosamples and what's available? I'm particularly interested in urine samples. Longitudinals are really precious. So.
Oh, well, we have a lot of urine samples, and I can see that my colleague Gail Laughlin is amongst the audience members here. I don't know if she wants to speak up, but we'd be more than welcome. We'd be more than eager to meet with you and talk about anything that you might want to do. You know, samples are, as you know, precious, but also if they're not going to be used, they're not of any use. So great. For people who want to do some interesting research, we're very eager to have them used.
Very happy to hear that. I definitely will contact you for follow-up. Thank you.
Okay, wonderful.
That was a great talk, Linda. Thank you very much. Do you have any information on hospitalizations?
We do ask them. They were asked in several visits, probably also in some mailers, the number of times they've been hospitalized in the previous year, and also the number of doctor visits. So it's one of the measures we use for like inferring health status at different times.
Okay, thank you.
Dr. McEvoy, it was a great talk. Thank you so much. I have a question about the retention. I know that you mentioned that Dr. Barrett-Connor was incredibly diligent about follow-up and keeping in touch with the sample, but I wonder if there were other activities or events or offerings that helped to retain the sample for such a prolonged period of time.
Yeah, so she would send out a yearly letter that I don't know if Gail wants to speak up, but that sometimes that had poems that she would write about the study. She would sometimes, they would go down there and host lunches at the Rancho Bernardo Inn for the participants, and they did keep in touch with them very closely. And we also had information on an informant, basically. So we had it. They updated that at every visit and every time they contacted them. So both they updated the participants' contact information as well as added somebody that they could contact if they lost contact with the participant. So yeah, they did have a lot of involvement with them. And they had a clinic right in the Rancho Bernardo community. So when they had their studies, they would just go there in Rancho Bernardo, which also helped a lot because they didn't like to come here actually. So for our Visit 12 study, when they had to come and do MRIs up here, that was a bit of a challenge for some participants. Some of them didn't want to do that. We did have a driver who would bring them here to make life easier for them. Some people, of course, wanted to come on their own and drive it themselves, but we did have to facilitate the transportation.
And I'll just add that that Dr. Barrett Connor, as Linda was saying, wrote a poem every year for all the participants in all of her studies, because she did a lot of clinical trials as well. And it was so clever. And the fact that she did it year after year after year and made it so interesting each time was remarkable. And she put together a little book of some of the primary publications. She would send a list of the primary findings for that year and highlighting the things that she thought would be of interest to the participants. They were devoted to her. There are people, many people, who came to every visit and answered most of the 32 mailers.
That was nice. When we were at the Rancho Bernardo Historical Society talk, a lot of people in the audience afterwards came and said, I was there in 1972 and I've been involved all along. I've been to every visit, and when are you going to bring me back? They were very eager and happy to participate. And they really, I think providing them with the information of what we've learned from the study was really important too. They were really proud of that.
They were competing with each other to see who was there for the most visits.
Thank you.
And I'll just say a little bit about the samples, Linda. So we have, as Linda said, we have serum, we have plasma, and we have urine samples. And for many of the studies, we were able to aliquot them. So we can pull single aliquots. One of the pieces of information that would be most important to know for any kind of proposed study is what volume, which substance you would want and what volume.
That's great. Well, we're almost at time, and it seems like the questions are petering out. If anybody has anything else they'd like to add, please feel free to hop in here, but I'm just going to go ahead and say thank you again. That was an incredibly thorough and very well done presentation. Enjoyed it very much. And it was a great way to go out with the series for 2020. So thank you so much for your time.
Thank you, and hoping for a lot better 2021.
Cheers to that. Yes. And we can all feel good in our drinking behavior during the holidays now that we've
yes. In moderation, only in moderation. Okay. Bye, everybody.
Thank you.
Thank you so much.
Bye, everyone.
Bye-bye.